Hi, I'm Shannon. I'm a nursing student at San Jose State, and I'm going to be sharing with you a two-part series where I discuss fluid and electrolyte balance. And this part one, I'm going to focus on the fluid balance in the body. Fluid balance in the body is a very important issue that students need to understand. It can be a very strong indicator of our patient's disease process as well as their response to treatment. And we know that most of the fluid in the body is held inside the cell. 2/3 of the fluid in our body is in the intracellular space, and only 1/3 is extracellular and is outside the cell. And the way that the body consistently tries to provide homeostasis is through shifts in the fluid. And homeostasis through fluid shifts is maintained by hydrostatic pressure and oncotic pressure. And we know hydrostatic pressure is the force of fluids within a fluid compartment, like blood pressure. And osmotic pressure is the pressure exerted by the solutes within a fluid space. So to give you an example of osmotic pressure, let's say that we have a vessel here. This is our vessel. You can see it. And my solutes are these little food puffs here, corn puffs. If my vessel has fewer solutes in it than my cell does, this is my cell. Let's say that my vessel is hypotonic compared to my cell, then that means that my fluid is going to follow the solutes and is going to enter the cell. Okay? That is osmotic pressure in action when the fluid follows into the cell. The cell is going to swell. That's going to give us some symptoms that we're going to see. We're going to notice that in our patient. Now, if it's the opposite way, let's say that my cell has fewer solutes in it than my vessel does. Let's add even more here. Okay, can you see it? Where's my fluid going to go now? It's going to go outside the cell, and my cell is going to shrink and dehydrate. Okay? So remember that when we're talking about fluid shifting. Okay? So the way that we test the amount of solutes per fluid in our vessels is by testing its osmolality. Serum osmolality is the measures osmotic force within our vessel. And the reference range for it is 275 to 295 milliosmoles per kilogram. If we have less than 275 milliosmoles per kilogram, that means that we have a decreased solute concentration in the vessel or a fluid excess. If we have greater than 295, that means we have an increased solute concentration or a fluid deficit. So let's talk about volume deficit first. So fluid volume deficit can occur because you either have lost water alone, or which is dehydration, or fluid volume deficit where you're losing both fluid and electrolytes, which is more common. So volume deficit can occur because of trauma or hemorrhage, diarrhea and vomiting, excessive sweating, third spacing due to burns or peritonitis, and renal issues can also cause volume deficit, including diabetes insipidus, kidney disease, and diuretic therapy. So I want to touch on diabetes insipidus really quickly because it's a really important idea to grasp a hold of. It took me a while to understand what it was, and I had to keep looking it up, so hopefully this will help you guys. Diabetes insipidus doesn't really have anything to do with the diabetes type 1 or 2 that we're used to talking about, diabetes mellitus. It is actually a water issue. A decreased function of ADH, which is also called vasopressin, in our body. And ADH, as we know, is anti-diuretic hormone. So if it's an anti-diuretic, that means ADH is supposed to help us retain water. So diabetes insipidus is a decrease in the ADH in our body, or in the function of ADH. Then that means we have a huge amount of water loss. ADH is not functioning, we aren't able to retain that fluid, and we're losing a lot of water. You're going to see some of the similar symptoms in insipidus as we do in diabetes mellitus, like polyuria, which is an excessive amount of urination, and polydipsia. And dehydration can occur when you have that happen. Okay, so that's a really big one to understand. Let's do a head-to-toe of symptoms with fluid volume deficit. Neurologically, you might see your patient dizzy, weak, confused. Cardiac, you're going to see tachycardic and hypotensive, especially orthostatic hypotension. Decreased central venous pressure. And I like to go from heart to vessels because they're connected. Decreased in capillary refill, flat neck veins when you lay your patient down, and weak pulses. In our lungs, you're going to see tachypnea and hypoxia. And the reason we see tachypnea is because, think about if your fluid volume is low, your heart rate's going to go up, and you're going to have to work harder to provide oxygen to your vital organs, which means your respiratory rate's going to increase as well. In GI, you're going to see thirst, dry mouth. You may see nausea, vomiting, and diarrhea depending on what the disease is, and weight loss. We have to remember that weighing our patients is the single most important factor in obtaining their volume, fluid balance, or their fluid status. In the hospital, it's done daily at the same time every day, and it's really important to do. So weigh your patient. Weight loss is a big indicator of volume deficit. GU, oliguria, which remember is a decreased production and increased concentration of urine. And skin, you're going to see poor turgor and tenting, cool, clammy, diaphoretic, and possibly hyperthermia as well. As far as labs go, you're going to see an increase in hematocrit. Remember, hematocrit is a percentage of red blood cells in the plasma. If you have a water loss, a fluid loss, your hematocrit's going to go up. You're going to see an increase in osmolality, like we discussed, greater than 295. And you're going to see an increase in your solutes, protein, glucose, your blood urea nitrogen, and your electrolytes. Now to move over and talk about fluid volume excess. So things that can affect our volume and give us too much water include an excessive amount of sodium intake. This can happen with hypertonic solutions are given through IV and are either given at too great a rate or given inappropriately, and then you have too much solute, too much sodium inside the vessel, and you're going to retain water because water follows sodium. Diseases that stimulate the kidneys to conserve sodium, and water, because water follows sodium, include heart failure and cirrhosis. And an increased use of glucocorticosteroid use will also cause the body to retain water. And renal issues, again, let's talk about. Renal failure decreases the excretion of sodium, and thus decreases our excretion of water. And syndrome of inappropriate antidiuretic hormone. It's ADH again. Let's talk about this for a minute. So SIADH was something else that I had a hard time grasping a hold of that idea. It was confusing to me for some reason. It's the opposite of diabetes insipidus. We talked about diabetes insipidus as being a decrease in the function of ADH, which is vasopressin, which means we had a huge amount of water loss. Well, with SIADH, you have an increase in the amount of ADH in the body. Remember, ADH helps us conserve water, and if you have an increase in ADH, you're going to have an extreme amount of water reabsorption. Okay? All right. Let's do our head to toe for our volume excess. If you have too much water on board, you are going to see neuro symptoms of confusion, muscle weakness, headache. For the heart, we're going to see tachycardia, hypertension, because hydrostatic pressure increased, right? We have fluid volume excess. We're going to have high blood pressure. And you're going to see an increase in your central venous pressure. Bounding pulses and distended neck veins, they're going to be bounding and distension. Lungs, you're going to see tachypnea, dyspnea, which is shortness of breath, orthopnea, which is when you lay flat on the bed, you have a shortness of breath and you have difficulty breathing. Diminished breath sounds and crackles are very common. GI, weight gain, again, weigh your patient daily, the same time every day. And ascites, which is like third spacing. GU, it's going to depend on the cause. If you have renal failure, you're going to see a decrease in the urine output. Skin, cool, clammy, and you are going to see edema in your patient. For our labs, hematocrit, you're going to see a decrease. That percentage of red blood cell to fluid in the vessel is going to go down because you have a volume excess. And you're going to see a decrease in serum osmolality like we discussed. It's going to be less than 275, maybe less than 270. Decreased in electrolytes, your BUN, and your creatinine. Okay? Those are the key points I wanted to discuss. To do a quick review of what we've gone over, homeostasis is achieved by fluid shifts in the body, caused by hydrostatic pressure, which is fluid force within a compartment, and osmotic pressure, which is the force that the solutes create on the fluid. Fluids shift from a low concentration of solutes to a high concentration of solutes. The way that we test this balance in the blood is by testing our serum osmolality. Reference range is 275 to 295. And this tests the balance of solute to water inside our vessel, not inside the cell. Remember, we're talking about inside our vessels. A number less than 275 indicates a decreased solute or a fluid excess, and a number over 295 indicates a solute increase or a fluid deficit. And another topic I wanted to just point out really quick to you is our older adult community. They have a decreased thirst mechanism, a decreased kidney function a lot of times, and their body mass has shifted and gone down, which means their fluid balance is off to begin with. On top of comorbidities that they have, this puts our older adult population at a greater risk for fluid imbalances, so we need to keep an eye on them when we're in the hospitals and taking care of them. Okay? Thank you for joining me. I hope that this helped you. And if it did, check out my part 2 where I get into electrolytes.